Welcome everyone, and thank you for joining this session of the IANPHI Annual Meeting. I am Shelly Bratton, lead for US CDC's National Public Health Institute program, and it's really great to see so many familiar faces and names virtually. First, some housekeeping reminders. Please feel free to comment or ask questions in the chat throughout the session. You can speak and listen to the meeting in English, French, Spanish, and Portuguese. There's a button at the bottom of your screen for interpretation. The meeting is being recorded, and the recording and speaker slides will be made available on the IANPHI website. The purpose of this session is to think about strategies that NPHIs can use to address inequity. We're fortunate to be learning from Mexico, Cambodia, and Colombia about the activities led by their institutes that are helping to better understand and address health inequity. We will then open to the meeting to, I hope, a robust conversation, either in the chat or with hands raised, about additional tools members would like to highlight, or tools and approaches that members recommend developing in partnership with the IANPHI network. I will now turn to our first speaker, Dr. Rivera, Director General of the National Public Health Institute of Mexico. Dr. Rivera?
Thank you very much. I would like to ask if you can see my presentation.
Yes, we can. Thank you.
Great. Well, first of all, thank you very much for inviting me to share some of the experiences and strategies that we are either implementing or planning in order to improve health equity in Mexico. Thank you to the US CDC, Shelly Bratton, and of course, my colleagues from Cambodia and Colombia. I will really enjoy sharing with you this information and learning from your countries. So I'm going to talk mainly about an institutional program that we have implemented at the National Public Health Institute in Mexico on health equity, with a focus on our indigenous population. About 10% of Mexicans are still considered indigenous. And of course, most of the population is a mix of indigenous and non-indigenous population. So the first thing is that the mission of our institute is to contribute to social equity and the full realization of the right to health protection through research, postgraduate training in public health, and advice to government. So in our mission, the first words that you read is contribute to social equity. The second thing is that equity in health refers to the creation of equal opportunities to achieve a healthy life. Individuals and social groups are not placed on an equal footing to exercise their rights in the same way as we have seen also in the previous presentations. And it is necessary to identify these inequalities, which are structural and determined by mechanisms that cause them to systematically reproduce. And our institute has developed an institutional program on equity, and the aim is to contribute to equity in health through research, training, and service. And let me show you this slide, which is really revealing about the great inequalities in Mexico. This is population of children and adolescents in extreme poverty in Mexico. And you can see that indigenous households are 5 times more likely to live in a household that is in extreme poverty, 31% relative to non-indigenous population. This is something that has been part of our history in Mexico, and it really, one of our aspirations is to change this. So we recognize that the structural determination of inequalities, so this is a structural problem, and their unjust nature historically sustained in forms of discrimination and violence towards different sectors of the population, such as women, indigenous people, foreigners, the poor, etc. We recognize that social inequalities are not immutable, but that it is possible to transform and prevent them through collective action and public policies. And we have adopted a human rights and social justice perspective as a frame of reference to guide research, action, and decision-making. Here, another terrible slide of the gaps that we have in Mexico. You can see here stunting in our children less than 5 years. The prevalence at the national level is about 14%, but you can see that indigenous population, the prevalence is 31% against 11 in non-indigenous population. Again, something that should change. We also have gaps between urban and rural population, but the gaps with indigenous populations are even greater, as you can see. This is another information that is really very revealing. So here we have indigenous and non-indigenous population in the 3 Mexican regions, the north, the center, and the south. The south is much poorer in general, Chiapas, Guerrero, Oaxaca, close to Central America, the poorest area in Mexico. The north is the richest area in Mexico. And then you can see how indigenous population that live in each of those regions have different prevalences of stunting, but they are always much above the non-indigenous population within each region. So this is something that then we have to really work all over Mexico in all the regions. And by the way, I also wanted to share with you, and particularly because in the last session, this was the topic, some factors that were associated in Mexico with having antibodies against SARS-CoV-2 in a serum sample of a national nutrition survey, in National Health and Nutrition Survey during the pandemic. And let's center our focus on two of the information that we have here. First, in terms of schooling, relative to those who have university degree, all other people, primary school, secondary school, high school, have higher chances of being infected with SARS-CoV-2. This was in about August to November 2002. The other thing is that relative to the highest income tertile, the low income tertile had a 20% greater probability of being infected. Again, structural problems that led to inequalities, and we can see the inequalities in infectious diseases, chronic diseases, access to healthcare, name it. So the other thing that I wanted to show you is, for example, here, the mortality rate. The mortality rate in indigenous municipalities, so these are the municipalities that have more than 40% of their households defined as indigenous, is 14.4 per 1,000 births, compared to non-indigenous municipalities that are 10. So this is, again, shows that we need in Mexico a focus on equity in all our policies, of course, including health policies. So what are we planning to do? And of course, in part, we are doing already. In terms of research, document and monitor through quantitative and qualitative indicators, the way I have shown you with the graphs, inequalities that are unnecessary, avoidable, undesirable, and unfair in several areas: health outcomes, access to services, quality of care, social and economic determinants of health, and general living conditions. Then, in terms of training, I remind you that we are the Mexican School of Public Health, and we provide training to masters in science, masters in public health, and also PhDs and doctor in public health. So develop population-based training programs on health equity with emphasis on indigenous health. And this is not only on our curricula for the masters and PhDs, but on our continuous training to the public health force. Train postgraduate students as agents of change, and then affirmative action aimed at training students from indigenous populations in public health, particularly in the master's program on public health. This is something that we have not begun and is planned to begin in the next year. And then on our mission to advise government, first of all, inform government about these health inequities, and we conduct national nutrition surveys now every year, promote intersectoral work to reduce health inequities. The perspective of equity in health and social justice must be present in all health-related policies. And then a useful question for policy guidance is, how does this policy contribute to improving health equity, well-being, and social justice in general? And we would like that, you know, every policy be subject to this question. And then finally, we evaluate many of the programs, not only health programs, but also programs in social development and welfare. And we must apply an equity lens on the evaluation of those programs. Here, again, I'm showing you the percent of women who receive prenatal care during the first trimester of pregnancy in 2012 and 18. And you can see indigenous women on blue, lower prevalence percentages who receive prenatal care than non-indigenous women. Then in the next, sorry, and this was the last. So I just wanted to show you our plans, our strategies, and some evidence of the big gaps between different groups in Mexico, the inequities. Thank you very much.
Thank you, Dr. Rivera. It's really interesting to see the three-pronged approach by IANPHI, the research, training, and advice to government. And I really appreciate your comment that social inequalities are possible to change through collective action and policies. We'll now turn to Dr. Poor, Deputy Director for Cambodia's National Institute of Public Health. Dr. Poor. Great, thank you.
Thank you very much for this opportunity. So let me share a few lessons from the National Institute of Public Health in Cambodia in contributing to promoting health equity in Cambodia. So you may have been informed that Cambodia is one of the countries that made significant progress in improving health service coverage, as well as financial protection over the last decades. Especially, we are one of the few countries that have achieved almost all NPHI targets, except for tuberculosis. But when we see the figure of the improvement between different group of population, it shows clearly that there is an inequality or gap between this population group in terms of healthcare service coverage, health status, as well as financial protection. So this is the few figure to show that for skilled birth attendant in terms of service coverage, our 10-year period from 2005 to 2014, there's a huge improvement in terms of coverage of skilled birth attendants, but there's remain a huge also urban, rural, and poor-rich gap between the population group. The same for catastrophic health expenditure as well as impoverishment, mainly catastrophic health expenditure. You see that rural, elderly people and people with disability, and especially those with chronic diseases, are much at higher risk of catastrophic health expenditure as compared to other population groups. We also observe a huge inequity in health outcome as well. As you can see, the three health mortality and two mortality indicator in terms of infant mortality rate as well as underchild mortality rate compare urban, rural, and between educated and non-educated mothers, as well as the poorest and highest, richest mothers. There's a huge difference. The disparity also exists for the risk factor, as you can see here in terms of smoking. We see the lowest and highest income group has a huge difference in terms of smoking, percentage of smoking, and also in terms of educated and non-educated. And Cambodia is a little bit specific country that women, very few women smoke, only mostly men. So in this situation, with the huge improvement in healthcare coverage and disparity of healthcare coverage, health status as well as the outcome, further improvement in healthcare coverage and health status as well as financial protection needs specific intervention to focus on particular or priority population group. And by doing so, we can also help the country to move gradually to achieve universal health coverage as well as the sustainable development goals. At the same time, also preserve social justice and human rights. And to achieve that, it requires first a better governance for health equity, including health inequality monitoring. Look at the health equity governance in Cambodia. In general, Cambodian government policy focus also prioritize health equity, starting from the top national constitution, also stipulate clearly about free medical care for poor people, and also building infirmary and maternity care in rural areas as a priority. At the same time, the National Health Strategic Plan also putting emphasis on access to equitable and quality healthcare for all as a UHC, without leaving no one behind. And recently adopted the National Social Protection Policy Framework also consider universal social health protection as well as universal health coverage as also a priority. In country, there's a number of existing multi-sectorial institutional mechanisms and structure to support the progress to sustainable development goals, social protection, and universal coverage. For example, there is a sustainable development goal led by multi-sectorial technical working group or the Ministry of Planning. And then inside there is a social protection led by the National Social Protection Council and its supporting structure, which include the executive body and general secretariat. And more specifically in terms of social health protection or universal health coverage is led by the Department of Planning and Information at the Ministry of Health, associated with a number of working groups, including the working group for National Health Account. But in the country, by last year, there was no really a health equity specific multi-sectorial mechanism or structure, or there's no systematic means to monitor the health equity yet in the country. Therefore, the National Institute of Public Health in Cambodia, which is a semi-autonomous public health institute in the country, has made some contribution to promote health equity in line with its mandate that includes three main functions. First, NPHI have a public health laboratory serving as a national reference public health laboratory. Also, NPHI has a public health teaching and training program, mainly the master degree program, and then also have a component about public health system research and policy support. In line with this function, NPHI has organized and participated in a number of national and international workshops to raise awareness and deepen understanding of health equity issue among key stakeholders, for which we consider as the most important, because before putting or setting the agenda and mobilize their support to promote health equity, first we have to make sure that key stakeholders understand what is health equity, the importance of health equity, and the situation of inequality in healthcare in the country. We also join with a couple of key stakeholders, including the WHO and Ministry of Health, to conduct an equity situation analysis in the country to provide a basis for the discussion or for joint action to promote health equity. We expect that after this, there will be an action to set up a multi-sectorial institutional mechanism and structure for health equity governance. We also expect the development of equity monitoring system as part of the SDG and UAC monitoring and evaluation framework, and also the development of specific multi-sectorial action plan to address health inequalities, as well as to advance the SDG UAC progress. But this has not been happening yet, because it's still on work in progress. The National Institute of Public Health also created a team at the National Institute of Public Health and build this team capacity in analysis of national survey data, mainly demographic health survey and socioeconomic health survey, a population-based national representative survey, for equity monitoring as part of the SDG and UAC framework. We did so because often the work have been done by the external consultant, and we thought that it's not very sustainable, and we need to institutionalize this work to sustain the work for the future. And NPHI also were asked by the National Social Health Protection Council to help them in monitoring UAC. It means to compute UAC indicator with necessary equity stratification, mainly by resident, urban, rural, by socioeconomic group, as well as the education. And NPHI also developed a course on UAC and health equity as a part of its master programs. At the same time, NPHI also try to promote health equity and introduce the equity concept as an integral component of the management and leadership training for hospital and health center managers, a course that NPHI has just successfully developed for already 3 years. At the same time, NPHI also make use of the opportunity of NPHI linked with the public health facility to set up a network with them, try to make use of this network to set up equity health service promotion. For NPHI, health equity is also considered a main priority for health system research. That's why we had a number of research projects directed to equity. For example, we have joined a consortium, a research consortium on system-wide analysis of health financing equity in the country. And we have published a number of papers, and also we have a policy brief to advocate for equity promotion. So what can we learn so far? First, we think that the National Public Health Institute, like National Institute Public Health, with a similar context like this, the Institute can play a crucial role in promoting health equity through a number of equity-oriented actions. So this includes the training and capacity building around health equity analysis, also research as a function of an IPA, technical support, mainly support the government department where they have the role in monitoring equity. So to set up equity analysis and monitoring evaluation system. To develop equity network among health manager and policymaker, and also to raise awareness and deepen understanding through a number of workshops or participatory activities. We believe that setting up an effective equity governance and monitoring system for equity, especially with the local capacity, is key to sustainably improve country equity and achieving UAC. However, this work is really a challenge because many of the work have not been achieved yet so far. We have started 2 years ago, but we progress slowly. And this work is really challenging because it requires multi-sectorial approach, which involve many partners beyond the health sector. Thank you for your attention.
Thank you, Dr. Poor, and interesting to see the overlap between some ideas you just described for NIPH and what Dr. Rivera described from INSP related to data analysis, capacity building, and training in general, and also how the NPHI is providing that advice to government. Our final presentation is from Dr. Castañeda, Director of the National Health Observatory at the National Institute of Health, or INS, in Colombia. Dr. Castañeda.
Hi, everyone. I will speak Spanish. Cordial saludo, un agradecimiento.
In Spanish, I'd like to greet everyone, to thank Fiocruz and IANPHI for this invitation to share the lessons learned. I'd like to also greet to show progress that has been made in the analysis of health inequalities, especially from the economic perspective. The observatory was created about a decade ago, and it includes analyzing social determinants in public health. We have carried out a number of analyses to show inequalities through different socioeconomic elements. So we show the gaps and inequality gradients depending on social position. Here on these graphs, we have results related to education, wealth in the Colombian population with a prevalence of chronic malnutrition depending on educational level of the mother, which is higher among children with these various social characteristics. Same thing with wealth. Mothers who are very poor also see these reflects on their children. Chronic malnutrition, very similar to the scenario on the mother mortality graph. Pregnancy, and so on. Also reflecting challenges in education for women. Then we look at the role of ethnicity in healthcare And we had a study specifically in indigenous communities. Although it is a minority, it is important to point out they also have issues with nutrition, and there is a mortality rate for child life expectancy related to nutrition. All this related to socioeconomic elements. Although there has been improvement in the average in the population as a whole. So the averages do not show the same behavior for all groups. Social class we used different types of information sources, including surveys, which made it possible for us to analyze elements of work, labor, how to place people in social levels. And what we see is that results vary depending on life conditions, health conditions, as well as social aspects. Social classes correspond to farmers, agricultural, domestic workers with the worst indications, with difficult health conditions, and also disadvantage from the pension plan's point of view. And those with jobs and in different social positions have very different results. Here, looking at Colombia, there has been an armed conflict, and this is also reflected in the various analyses. And the way we can observe cities that historically have been more exposed to armed conflict and also have health issues and health inequalities. Also, mortality challenges more intense in conflict areas, also showing worse results in these indicators. Same thing for malaria, skin disease, and other vector-borne disease classified by armed conflict. So we see that these conflict zones are affected by a number of these diseases. For COVID-19 pandemic, a more recent crisis, we see a lot of inequalities. The pandemic, as well as their side effects and impacts on health, which shows that these gaps have been kept. In some cases, have even worsened with the pandemic. We see that there are ethnic populations belonging to certain groups have a higher risk. In the lower part of the slide, you see how, in addition to increase in mortality, we see mother mortality before the pandemic and during the pandemic. And we have an indicator that things have worsened in Colombia, and the gap has increased among more vulnerable populations in these various cities. And we see how measures have attempted to mitigate inequalities, but 12%, a lot to do with maternity, mortality of mothers. And my final comment, advances and challenges to reduce health inequalities in Colombia. I'd like to say that Colombia has incorporated this perspective of social determinants, launching health programs of the health sector with research and monitoring of social inequalities in health. A number of institutions and administrative levels in the country working in this sense, and there's confirmation of an intersectoral commission to address the social determinants. All this within the health planning framework. We have challenges acting on the structural determinants that implies deep social transformations in various dimensions of life. Also, advancing in the implementation, reaching the most remote areas, being present and provide services to these populations. Also, strengthen the health system to improve access to services and health prevention, as well as proximity promotion from an equity approach. To continue progressing, one needs to create indicators. Thank you.
Thank you very much, Dr. Castañeda. Wonderful to see the data analysis led by the National Health Observatory. I'd now like to open it up for discussion. If you have been following the chat, Dr. Poor, there's some specific questions in there to you about your universal health coverage. We also have 2 questions that I'd like to open to the panel, generally to all panelists. Before doing that, I'm going to turn to Felix Rosenberg to comment on some analysis. Felix?
Yes, good day, everybody. Thank you very much, Shelly. Congratulations to Carlos, Juan, really beautiful presentations. I would just like to add, because it seems that everybody agrees upon the structural origin of inequalities. And on what Juan very clearly mentioned, that this, because they are structural, they are reproduced. So what I would like to just mention, and which I didn't see really, which I think is really a complement, a very important complement to act, to intervene upon this structural inequality, is that there is an absolute clear, necessary relationship, as we say, dialectic relationship between the structural inequality, which Carlos mentions as principally a social class related to occupation, labor, and so on, profession, so on, and the territory, the place where these people live. I mean, there are really determined placing of the people, where people, different classes live, is related to territory. And because the big challenge, as everybody mentioned, is an intersectoral intervention to reduce this social structural determination, you can only work really intersectorially at the local level. It's extremely difficult, I would say almost impossible in our political systems to have an effective intervention, intersectoral intervention at the national level, taking into consideration specific determinants like ethnicity, gender, depending on the place, war in Colombia, indigenous in Mexico, immigrants in Europe, etc. But all of them are related to a reproduced condition. In our countries, in South America, Latin America in general, it's ethnic, because the slavery determination has never been absolutely solved. So there is a reproduction But so what I would like to suggest that in those observatories, like Carlos Castañeda mentioned, Colombia, and the work with Juan, with indigenous people, and is that the observatories will focus on local, on territorial differences, so that you can really map territorial conditions at the smallest geographical possible level. That is, many of you have mentioned municipalities. In Sao Paulo, we have excellent information on neighborhoods. We have specifically worked with COVID on hotspots. The hotspots of permanence of the disease will show you those territories. So I would like to suggest that we, in some occasions, Shelly, can have a workshop to really define methods on how to observe territories, deprived territories, because those deprived territories will synthesize somehow those conditions, those deprivation conditions. And this would allow to have an local intervention, intersectoral intervention, working with the local municipalities or the local governments, depending on the countries. Thank you, Shelly, and congratulations for this, this session.
Thanks so much, Felix. I appreciate your suggestion. I'd like to follow up, and this actually relates to Felix's comments about that intersectoral approach, because there's a number of questions in the chat. And Dr. Poor, I think this stemmed from your comments about intersectoral action plans and related to these social determinants of health, how that is managed, how that comes together. And so if you could talk a little bit more, and obviously, Dr. Rivera, Castañeda, if you have comments also, please too. But if NIPH is leading that planning or pulling together groups, or you also talked about existing multi-sectoral groups, but how NIPH is playing a role and how that planning is coming together.
Thank you, Shelly. I may disappoint you because, as I said, we tentatively try to achieve that level, but we haven't done yet. So what we see the pathway that by starting working together with the key stakeholder, especially the one who have the power in decision making in the country, and by having a good relationship with them, and the National Institute of Public Health make use of our capacity and recognition by this partner, we can try to initiate, a couple of platform or kind of opportunity to gather them to come and talk and discuss about the issue first before moving further. And by doing so, as you see now in Cambodia, we have a couple of institutions like the National Social Security Fund working on the expanding social health insurance coverage. We have the National Council for Social Protection working on monitoring social protection, including social health protection. We have the Ministry of Health on board. And then at the same time in Cambodia country, we also rely partly on the still external funding. Some donors also have a role to play. So especially WHO, the World Bank, and this partner are also key stakeholder. So we join forth with them, we successfully set up kind of a platform through face-to-face meeting as well as also discussion. But for the moment, our ultimate aim is to set up a working group, a multi-sectoral working group, but we have not succeeded yet. So it's hard to say how exactly, because we're still looking also for a way to do that. And there have been some example also in this multi-sectoral working group, but not specifically for health equity, but for other social determinant of health, including like tobacco control, like antimicrobial resistant, non-communicable diseases, risk factor, and so on, Cambodia has been a country that, dialogue between key stakeholders and partners have been quite smooth so far. So I hope that we will succeed, but it takes some time because it's also often sometimes related to financial commitment for the policymaker, even they understand the need, but they have also to access the ability to afford it before they can just moving forward or not. Thank you.
Thank you. And Dr. Poor, I'll turn your attention to the question specific to universal health coverage and your comments there in the chat. Feel free to respond directly to that comment. Before we move on, Dr. Rivera or Dr. Castañeda, any comments around that intersectoral approach? And yes, please.
No, I completely agree that we need a multi-sectorial approach. And I also agree 100% with what Felix just said about the importance of local surveillance and local action at the territorial level, which is, of course, not easy. It's much easier to design and implement federal programs than do specific work at the local level, but that's very important. And just to let you know that our institute is involved in the design and evaluation of social development policies. And one of our aims is to include health concerns in those social development programs. For example, in Mexico, some of the social development approaches used in the past were conditional cash transfers that were conditioned on the investment in health services, nutrition services, and education. This government, when it came to power, they decided to remove the conditionality, because in a way, you are precluding people, and maybe poor people, to receive those services because they are not complying in a way, and so you are precluding them to receive the cash transfers. Now, unfortunately, the COVID pandemic came in the middle of the reform, and we are now in Mexico in a limbo, because we have the cash transfers to very poor people, but they are not linked to services. So that's something that we really should try to do. And then finally, just a brief comment about a strategy of the Mexican government, which is an intersectorial group on health, agriculture, education, and competitiveness. And the aim is to transform our food system into a system that is healthy, sustainable, and fair or just. And that involves all these sectors. And it is a very interesting group in which we are trying really to build policies that are looking into this equity issue related, of course, to health, education, and agriculture.
Thank you. Dr. Castañeda, any comments before please?
Yes. Okay. In Colombia, the framework of the social health determinants by the WHO was an opportunity to include all the intersectorial approach in the public policy planning, and the Minister of Health has a really big effort to according with different sectors, some policies that try to address the determinants, the social health determinants, and some intervention was planned in the core of the social health, in the intersectoral commission at the national level. But the problem is that the implementation of these efforts need a very local perspective. It's difficult in a country like Colombia that is very diverse in geographical and social aspects. Then, in many cases, the national policies are very difficult to be implemented in the local context, and a lot of the context variables are need to be analyzed and taken into account to reach the goal of the intervention.
Thank you. I'd also like to point out, Jean-Claude, and then we'll come to your question, but point out Anne-Catherine's question in the chat. There was mention of equity networks among health managers and policymakers. And if there's any experience with such networks, and what is the role of the NPHI? Any comments there from the panelists? You can see the question in the chat if you'd like a little more time to think about that. Jean-Claude, turn to you.
Yeah. Okay, sorry. Yes, thank you, Shelly. Thank you very much for this very stimulating session. I just wanted to echo to the comment that Felix made in terms of territories. I think it's all agree that it's a very important issue, and that solutions have to be developed in the context of, in the territorial context, either social and also infrastructure and all of those aspects. But I think also it have an influence on how the National Public Health Institute, that sometimes that usually most of the time have a national mission to organize themselves to be able to support the delivery of intervention at territorial level, which I think is a new dimension, at least to some of us, and particularly at Santé Publique France, we have the chance of having regional offices of Santé Publique France, which have provided much more interaction with local policy makers and local structure to adjust response to health inequity and the social gradient. So I think maybe it's something that we should try to reflect in the Rio Declaration that has been circulated so far, and also the other issue that has been mentioned by some of the speakers. Thank you.
Thank you, Jean-Claude. Appreciate that. I'd also like to point out Quentin's comment in the chat about where the NPHI role may lie, and also where those limitations might be, and the need to advocate for legislation, as an example, to really mandate that multi-sectoral approach. To turn now just to a final question, also received a question about Indigenous communities, and recognizing that these communities have rich traditional medicine customs and leaders that sometimes can be at odds with modern medicine, making it difficult to improve certain health outcomes, such as vaccination. When it comes to reducing health inequities in Indigenous communities, how do we take that into account when crafting community programs and public policies? And I can post this directly. This question came directly to me, but I can post this directly to everyone. But I wonder, Dr. Rivera Castañeda, I know you talked about Indigenous populations, if you have comment there.
Yes. So in Mexico, within the Ministry of Health, there is a unit that takes into consideration the traditional healthcare practices. And one of the things that has been useful is, first of all, to identify that, most of the practices come from a very long tradition. And the first thing is that most of them are not harmful. And so there is a way to train these local healers so that they continue using most of their strategies, but at the same time, they complement with modern medicine based on evidence. Of course, there are some instances in which there are clashes, but in many instances, it is possible to bring them as to be part of the local teams, of the local health teams. And there are very interesting experiences. And that, of course, includes birth attendance, for example, that in our indigenous communities, the women are the ones who, the midwives, local midwives. And of course, they have incorporated some practices that are very useful and that have been developed through evidence. So the big message is that there is not necessarily a clash, and that you can include those local health persons into the health team.
Thank you. Dr. Poor?
Thank you, Shelly. I just would like to respond quickly to the question about how Cambodia approach UHC in public health. Just to highlight that, Cambodia has been so successful in providing access to primary health care, and in terms of increasing access in health service coverage, primary health care, for instance, maternal and child health services especially. But the challenge is that healthcare quality remains a problem in both public and private sector. At the same time, the system still heavily relying on out-of-pocket health expenditure. So for the moment, the government has made a lot of effort to further strengthen the primary healthcare system to enable access to primary healthcare, but at the same time also to promote the delivery of some certain healthcare services, especially for the chronic diseases service care in the public sector, at the same time and also improving the quality of care, and to address the out-of-pocket expenditure that lead to a catastrophic expenditure and impoverishment. In addition to the government direct subsidy to make this primary health care available free or sometimes at a subsidized price, the government also make effort to setting up a social health protection scheme, social health insurance scheme, like the Health City Fund, the recent social health insurance scheme by the National Social Security Fund expanded to the informal sector, and so on, so on. But we remain, we still have a question about how to reach the not so poor but near poor or not rich informal sector for the moment, as in addition to the government direct subsidy. Thank you.
Thank you, Dr. Poor. And I know we are almost at time. I would like to thank the panelists for presenting and sharing their country's story and NPHI role in addressing health inequities. Also to acknowledge in this conversation, thinking about the takeaways and the role of the institutes in analyzing data and presenting those data and helping the NPHI, the Ministries of Health, make decisions around programs to address health inequities. And also, Felix, I think your call for a workshop to focus on local level issues and the data needed and programs needed at that local level to address these issues. So really good takeaways, and appreciate everyone's input to this session, and hope to see everyone tomorrow in the next session focused on climate change, and then the final closing session of the annual meeting. So thank you very much for joining us. Good day.
Thank you very much. Brilliant. Really great.
Second.